Okay, welcome and thank you for joining. My name is Melanie Betancourt, and I'm a health educator for our community health here in Atlantic Health System. So tonight's webinar, Be Fast for Stroke, is presented by Lori. But before we begin, we have, of course, a few announcements. So this webinar is being recorded. All participants will be muted. If you have a question, please use the Q&A button and the chat feature for comments. We will try to get through all the questions at the end of the presentation. And lastly, are you or a loved one interested in smoking cessation? Atlantic Health System offers a free quit smoking program. This program includes an individual assessment, free nicotine replacement products, and 6 weekly group meetings to help you quit and stay smoke-free. There are multiple dates and times available, with group available in person or virtually. For more information about these groups and other resources for additional dates and times, please call 1-844-472-8499.
First of all, thank you so very much. I am so excited to do these programs. I just enjoy getting out there and getting to share the good news on stroke and how to avoid it yourself, as well as some risk factors that we can modify. I'm presenting a program tonight that was originally designed by one of my peers, Erin, who is the stroke manager up at Chilton. So she just graduated with her doctorate, and she's out celebrating with her family this week. So I'm very, very happy to be here on her behalf and to share this with you guys tonight. So we do have some objectives for today. Hopefully at the end of the program, you guys will feel comfortable identifying the 2 different types of strokes, listing some of the common signs and symptoms of stroke using Be Fast. So of course, that's the name of our program tonight. So, we're going to wrap that in there, and we'll spend a few minutes getting ready for that, and then we'll introduce the Be Fast. We want you to be able to identify your own risk factors for stroke, and also to be able to identify at least 2 modifiable risk factors for stroke. You guys answered those polling questions early, and we're going to go back to that in a little while and make sure that we cover that information for you. All right, so that's our plan for tonight. So here we go, jumping right in. We talk about Be Fast for stroke, and with that, we want to be fast because we don't want to delay our care. So together, what we want to do is we want to work together to end stroke. Ultimately, that would be our goal. And in order to do that, there's a lot of different factors that play a part. Of course, we want to, eat smart. Eating healthier gives our bodies better fuel, doesn't make as much bad waste that gets in our way and produces, that extra cholesterol and things. We want to be well overall. That includes being well with our emotional health as well as our physical health. And of course, down at the bottom, we want to talk about moving more. And that's going to be getting rid of that sedentary, lifestyle, just getting you to move more. The last few years have been really tough, and we've all been kind of stranded at home and really taken out of our routine. So this is the time for us to recover and really take charge of our own well-being again. So hopefully we're going to get you in that mindset tonight if you're not already there. With our stroke facts, we know that stroke is a really top killer, and we don't appreciate that as much as we should. But stroke is our 4th leading death in the United States, right there behind heart disease, cancer, as well as our respiratory illnesses. So stroke is really a big one up there. The difference is that stroke is the #1 cost for disability. So it is the leading cause for disability and really long-term disability. So that's where we really want to focus, because if stroke doesn't kill you, it's probably going to leave a mark, and that's what we need to focus on. About 87% of all of our strokes are ischemic strokes, and that's when there's a blockage to the brain of that oxygen that's much needed, the oxygen and nutrients that's much needed to keep that brain working well. So with that, we want to keep in mind, we're going to focus on ischemic strokes tonight. We'll talk about some of the bleeds that can occur, but the difference between the strokes are ischemic, where the oxygen is being starved by a blockage, or hemorrhagic, where the flow gets so great there's a rupture to a vessel that allows more bleeding into the brain than is okay. So let's take a look. Who's at risk for stroke? As we know, there are some groups that are more at risk for having a stroke. And with that, we of course know women have an increased risk for hemorrhagic stroke and an increased risk for stroke overall because women tend to live longer than men. So that seems pretty self-explanatory. We also know that there are some ethnicities that are more at risk. So our African Americans are almost double that of Caucasians. African Americans are twice as likely to die from that stroke than Caucasians are. American Indians, Alaska Natives, African Americans are more likely to have stroke than the other ethnic groups. And that includes our Hispanic population as well. And Asians have a higher risk for hemorrhagic stroke as well. And I tried to really, go into more details with that. And there isn't a lot of data to show exactly why that is. It's just the frequency and the overall occurrences and the outcomes that we're able to really determine that there's a difference in those risks. So as we get more data and more, studies on those, hopefully we'll be able to really drill down and find out why those ethnicities are more at risk. Some would say it could be some of those healthcare disparities. So certainly the access to healthcare could play a part, but we just don't have that data finalized to be able to share that with you. And of course, things like income, access to insurance, and that can affect any ethnicity as well as all cultures as well. So what we want to do is we want to know, what are our risk factors? We know that our risk increases as we get older, because if you remember that stroke is a cardiovascular disease. As we get older, our vascular vessels, our cardiovascular system gets aged. So we get to be a rusty old car, right? That muffler system gets old, gets worn out. Well, the same thing happens with our bodies as we get older. So we can't expect to have vessels of a 20-year-old when we're up in our 70s. So that's just a fact that's going to increase. Now, there are ways we can minimize that. We'll talk about some of those as we get through this, but our risk is definitely going to increase as we age. As at the younger ages, men are more likely than women to have strokes, but again, men don't live as long as women do, so our risk ultimately is higher than men. Women are more likely to die from those strokes, though. And some would say because we don't seek care right away or as quickly as we should. We're used to just putting things off. So by the time that, women seek help, sometimes it is often too late. More than 58% of Americans don't know that they are at risk. So we're going to identify some of those risks and really try to enlighten ourselves. And let's face it, none of this is rocket science new information. You've heard most of this before, so hopefully we're going to refresh that knowledge, put it in the forefront, and get you thinking about that again to actively look to address your risks. So when we look at a stroke is a medical emergency, okay? As a heart attack, we know that's a heart attack, that's serious, we've got to get help right away. So what we want to start doing is utilizing stroke, the terminology brain attack. If we talk about a brain attack, it's likely to better increase that thought process of it's a true emergency. I can't tell you how many times we have people that wait. They had some symptoms yesterday. They went through the day. They felt a little worse. They thought a good night's sleep would help. And when they woke up this morning, those symptoms were much worse. That's what we need to get away from. We really want to see folks right away to be able to recognize and treat that stroke as a medical emergency. There are treatments available if we get to them very quickly that are not available as time goes on. So the brain attack actually has the brain cells that start to die from the infarct. The infarct is that damage that's occurring. If you look on the screen, you see that gray area. So that's the area that's being affected by the infarct. If the infarct is a Hemorrhage, a rupture of the vessel, again, you can see that area that's being affected. That's what's really important for us to address early, because if this is a blockage in this one on the left, if there's a blockage there and we can recognize it and treat it early on, that patient may be eligible for a medication that can dissolve that clot and restore that blood flow before that damage becomes permanent. And that's really ultimately our goal. If a hemorrhage occurs, if we can catch it early on, if it's a serious hemorrhage, we might be able to do an intervention with surgery. If it's a mild hemorrhage, we might be able to reverse with medication their bleeding efficacy. We might be able to reverse like a blood thinner that they're on. So again, it's really important to recognize these things early on. So that's the issue. Brain cells are lost every second, every minute, and certainly every hour. So we want to be able to catch it, correct it, and try to reverse it. We also mention TIAs every time we talk about stroke, because these are very similar to a stroke, but they usually resolve. Those symptoms will resolve. You may have heard that a TIA is a mini stroke. A TIA is actually a transient ischemic attack. So it's that blockage of that vessel, whether it be through a spasming vessel or whether it be through those little clots that block those arteries temporarily and maybe restore flow on their own. So the symptoms come and go. They wax and wane, but generally they resolve very quickly. So the TIA is a big warning sign for us, and we're going to treat it the same as we would a stroke. We're actually going to treat it as if there is a stroke occurring, and we're going to then work that person up as if they were having a full-blown stroke, because it's important to use that as a warning sign and to find out what risk factors do they have, what can be changed or modified, do they need medications for some of their risk factors. So we do take those TIAs very seriously, and we're going to address it as a stroke initially until we determine that it is just a TIA. So do you know your risk factors? Let's find out. We have a stroke risk scorecard. This is just one of the nice tools that's available out there. You can pick this off the National Stroke Association website. You can go to the American Heart Association website at heart.org. There are so many tools out there. This is just one of them that allows you to take a look and see, do we have any high risks in that red column regarding blood pressure, atrial fibrillation, smoking, cholesterol, diabetes, physical activity or inactivity, our weight, do we have a family history of stroke? So if we have those in the red zone, that's pretty concerning. If we have more than three or more in that red zone, that's something that we really want you to seek medical attention right away. We want you to see your doctor and start to work on how you can lower those risks. Now, were we a smoker and we're trying to quit? That's going to move us into the yellow zone. So the yellow zone, that's awesome. That means these are cautionary areas. So if we have 4 to 6 of the yellow zone, there are several risks that put you at elevated risk for that stroke. And these are things that we might be able to address, modify, decrease, or eliminate from our lifestyle behaviors. And then, of course, we've got the lower risks ones. So this would be the non-smoker, somebody that's got their cholesterol under control. They don't have diabetes. They exercise 3 to 4 times a week. That's what we're looking at. And that ultimately is where we all want to land for the lowest risk for having stroke. And keep in mind, when I say lower your risk for stroke, I'm actually saying lower your risk for stroke, heart disease, some of those real serious medical emergencies, because again, it's a cardiovascular disease, okay? Cardio meaning heart, vascular meaning vessel. Well, that same vessels that go to the heart go to the brain and makes it a cerebrovascular issue. So those vessels that are supplying the brain can be obstructed just like as if they were supplying the heart. So these risks go hand in hand for heart disease as well. So let's talk about blood pressure. Blood pressure is often known as the silent killer. You might have heard that because how many people have high blood pressure and never know it? If they don't see a doctor on a regular basis, they're not having their blood pressure checked. They don't have a nurse in the family that bugs them about it, or maybe they do and they don't listen. Um, but blood pressure is really key because if you think about the blood pressure is the pressure exerted on your vessels as your heart is pumping and at rest. So the blood is being pushed through a vessel, and the top number is that pressure exerted on the vessel while it's pumping. And then when it relaxes, every time the heartbeat relaxes, the bottom number is the pressure exerted on that vessel at rest. So those two numbers tell us a lot. By the upper number and the lower number and the difference between those numbers, they tell us a lot about what's going on with your vessels and the vascular system. So that's why it's important to measure your blood pressure. It is the major risk for stroke. It is the major modifiable risk with smoking for stroke. So it occurs when the pressure of the blood in your arteries and other vessels is too high. There's often no symptoms, or the symptom is a stroke. Lifestyle changes can lower your blood pressure and reduce your risk for stroke. Not only lifestyle changes, but medication. Now, medication can fix a lot of things. However, what we need to keep in mind is that if you're prescribed a medication for your blood pressure, it's really important you stay on that medication until your doctor changes the dose, alters the medication, or tells you it's okay to stop. Because sometimes, and we saw this a lot when we had the changes in our medical insurance. I was still working in the emergency department, and we saw a lot of people that lost their insurance with some of the changes, and they had to give up some of their medications. And what's really sad is that that can create a rebound. So your vessels have been trained with that medication to be under less pressure. And then all of a sudden that medication is taken away. And then that can make your pressure go up even higher. So it really is important to make sure that you don't stop those medications unless it's under the doctor's care. Smoking, we all know better, don't we? We all do. We've heard it. And honestly, the number of smokers that we see coming through the hospital as inpatients is so much less than it used to be. So kudos to everybody who's been a past smoker and quit, who is trying to quit smoking, at least cutting down your cigarettes. Every cigarette you don't smoke is less damage to your lungs and your vessels and your body as a whole. So good for you. American Heart reminds us that smoking is the #1 preventable cause for stroke in the United States. And a third of the coronary heart disease deaths related to smoking and secondhand smoke. 90% of the lung cancer cases are related to smoking. Smokers die on average 10 years earlier than non-smokers. And if that doesn't do it, for you gals out there, women who use oral birth control and smoke greatly increase their risk of stroke as well as pulmonary emboli. And that's making clots, extra clots that go to your lungs, and they can be severe enough to cause death. So it's really important. I know a dear friend of mine lost her daughter in her early 30s to pulmonary emboli because she smoked and was on oral birth control. And that just is so devastating. Shouldn't happen. Stroke risk is 2.5 times higher for smokers than non-smokers. So again, we know these are risks. We've heard this all before, but hearing it again and having that right out in front of us in numbers can really hopefully make an impression. Coronary artery disease, excuse me, and atrial fibrillation. So when we look at these things, the coronary artery disease, if you look over here at our vessels, we've got little cholesterol that our body makes and cholesterol that we pick up when we have, those rough meals or those saturated fats. Those are things that are normally, floating around in our blood supply to begin with, but they're mild. Just enough, as we said, our bodies produce cholesterol, so we expect we're going to have a little bit in there. Maybe your family history says you make extra cholesterol, so there's a little bit of that as we go. However, if we get a little too much of it, it can cause a buildup on the inside of the coronary arteries or the vessels in the smaller vessels throughout our body. This will form a plaque over time. And, I've been in this business a long time. I worked with the heart side of things for a long time. And the early studies with the folks from the Vietnam War, these are young men in their 20s. But when they autopsied the men in their 20s, what they found is that there was a lot of young men that already had that buildup inside those vessel walls. So that was pretty significant. That was a big eye opener for us way back then to say, you know what, we need to take better care of ourselves. We need to eat better, exercise better, and we want to avoid that from those young ages because we really don't want to see that until much later in life when it's just a matter of those rusty pipes getting rusty, right? So it can form the plaque. And what happens is when these little cholesterol buggers or little baby blood clots try to get past that plaque, they can't. So normally little clots that would flow right through are going to get lodged there on that plaque, and we might have a more total occlusion or blockage of that vessel. So that's how the coronary artery disease is going to play a part in us having a stroke. Then we also have atrial fibrillation. Now, if you haven't seen a commercial on atrial fibrillation, kudos to you for never turning on your television, but most of us have seen them. So the atrial fibrillation causes a little quivering in the upper chambers of the heart that allows blood to hang out there a little bit longer than it should, because we want blood to fill in and pump out, fill in and pump out. But with those little chambers up there fibrillating, letting that blood hang out a little bit longer, it doesn't get pumped out right away. And then it can form some clots. Those little clots don't belong there. So what happens when the heart actually is able to move that blood, it's going to push those clots out there. And that's when we get those little micro clots or those little clots flowing through our vessels. And then if it goes to the brain, it's going to be able to cause a mini stroke, or it's going to block a smaller vessel and cause an actual stroke. So those are two things that we want to pay attention to. Now, if you have AFib, can you fix it? Well, not entirely, but can you control it? By golly, you can. There are procedures such as an ablation, a cardiac ablation, that might be able to fix it if it's a problem identified in one area of the heart. If it's multiple areas, they might be able to treat it with an anticoagulant that will keep that blood from hanging out up there too long and forming clots. If it's going to hang out up there a little bit longer, the anticoagulant will not allow it to form those clots. So then when the blood gets pushed, it doesn't push those clots along with it. So there are ways we can address them. Now, cholesterol. I told you our bodies already make cholesterol, so we have to be careful how much extra cholesterol we bring into our systems. A little bit of cholesterol is good for us. A whole lot of bad cholesterol is not good for us. So our goal is to keep our overall numbers low for our total cholesterol. But what we look at is we have those HDLs and those LDLs. The HDLs, those are the better ones. So we want a good number of those, higher lipids to be there because they help us, they help our bodies. Our LDLs are those lower lipids. Those are the ones that we don't want to be too high. The goal is actually to have them at 70 or below. If they're 70 or above, we're going to look to see if we can get a statin, a medication on board that will help to lower those numbers. Now, if you're borderline, maybe between 70, 80, 90, excuse me, your physician may very well want you to try diet and exercise first. Because let's face it, you don't want to be on a medication you don't need. So if you can control it with diet and exercise, that is the first goal. And that's what we would want to try. If you get hospitalized for something funky and we do some blood work and we find out that you've got LDLs that are well over 100, well, my goodness, you're probably going home on a medication right away because we don't want to take a lot of time to mess around with those high numbers, okay? So your physician will look at your overall health and well-being and what other comorbidities or risks that you have, and then they'll address that with you. But overall cholesterol, we want your LDLs to be below 70, and we want your overall number to be below 200 and even under 180, according to some of the most recent studies. And I see some questions popping up. Don't worry, I talk fast. We're going to get to those questions, I promise. So ask your doctor if you are at risk for cardiovascular disease. Specifically, we want to look at those carotid arteries. The carotid arteries are the ones that feed the brain with that blood. So when you go to the doctors, you notice they take their stethoscope and they listen to your neck. They're listening to your carotid arteries. They're listening to hear how much flow they can hear through those vessels. And that's really the goal. If they start to feel that it's not as loud on one side as the other, or that maybe both sides aren't as loud as they should be, they might recommend that you have a carotid Doppler. That's a little ultrasound test that can check and measure the blood flow. These tests up here would be what the technologist would be looking for, and they can actually color in the ultrasound, make it show up with how much blood flow is going through there. And of course, down here, the same thing, the arteries that we looked at before, we're looking for that healthy artery to allow the blood to go through that lumen as much as possible. We want a wide open lumen or a wide open vessel. A partially blocked artery has some of that occlusion, like we saw earlier with the cholesterol. Some of it builds up and it doesn't allow that blood flow to go through. And then a blocked artery, this is when that plaque and that buildup gets so great, it doesn't take much to cause a blockage of that vessel in its entirety. And a blocked carotid artery is going to cause a pretty big stroke because that's a large vessel that's supplying a large portion of the brain with that blood and nutrients that it needs. So diabetes, okay, knowing the symptoms. And I have to say, I don't know where Erin found these cartoons, but I love them. So are you always tired? Do you frequently urinate? Sudden weight loss. I know you got excited, but maybe it wasn't always a good thing. Do you have a wound that won't heal? Maybe some sexual problems, lack of energy, sustainability, you're not interested. Are you always hungry? Blurry vision. Get any numbness, tingling in those hands and feet, that you can't really account for sitting cross-legged for too long? Are you always thirsty? Do you have a lot of vaginal infections? These things are all signs that you might have elevated blood sugar levels. So if you have extra sugar in your body wants to rid itself. So you're urinating a lot, but then you're thirsty and you're hungry because it's got so much sugar, but it doesn't realize it has so much sugar. So it wants to keep feeding it. And then when you have all that sugar, your body's exhausted because too much sugar isn't good for us, right? So we're very fatigued. Too much sugar will not allow us to heal properly. So it's important, if you have a wound that's not healing, maybe it's time for you to get some blood work and find out how you're doing. Do you get them checked regularly? Hopefully, if you're getting an annual physical, you are. If you have any family history of diabetes, you've got siblings, parents, aunts, uncles, grandparents, then you're a little bit more in tuned, a little more aware that you might be at increased risk, and therefore your physician is keeping an eye on you. Some of the top foods that are bad for diabetics, foods that are high in sugar, the white breads, fatty meats. Not only are they high in sugar, but cholesterol. Sodas, we all know sodas beat us up really bad. Potatoes and French fries, those white vegetables that don't have a lot of nutrients in them. Canned fruit juices, white rice, sugar loaded cereals. Those are things that we want to avoid if we are diabetic. The sugary fruits we need to avoid. Pancakes, don't they look good? Pancakes with waffles or syrup. We want to make sure that we minimize our intake of those as well. And of course, those flavored coffees. I recently got a Dunkin' Donuts close to my house, and I am just as guilty as the next. Every now and then, I just want one of those big flavored lattes or coffees. But, as we say, anything in moderation is okay. But these are the things that we want to avoid in regularity. We want to avoid in any excess. Alcohol abuse. Now, nobody's telling you you can't have a glass of red wine with your dinner, because actually there's a lot of heart benefits to that. But drinking too much alcohol can raise your blood pressure levels and again, increasing your risk for stroke. Drinking too much can increase your triglycerides, which is a form of fat that's part of your cholesterol breakdown, which can then harden your arteries. Women should have no more than 1 drink a day. Men should have no more than 2 drinks a day. So we need to keep that in mind. And what constitutes a drink? Generally 12-ounce beer, 5 ounces of wine, 2 ounces of hard liquor. But what are we mixing our liquor with? If you're mixing your liquor with soda or with fruit juice, then obviously that has increased risks with that sugar increase intake. So now we finally get to the Be Fast. So we've talked about the risks. We've talked about things that we can do to reduce our risk for being at risk for stroke. Now let's talk about how to identify a stroke that's occurring. Now, if you've had this years ago, you remember we used to talk about FAST, the face, arm, speech, and time. I've been doing EMS for a very long time, and we used to refer to that as the Cincinnati Stroke Scale. So we would use that to determine if somebody was having signs of a stroke. What we realized, though, is that the face, arm, speech, time test was only picking up on a large percentage of those ischemic strokes, but we were missing about 15% of them. So what we've done in recent years is we've incorporated Be Fast. Be Fast for stroke. Utilize Be Fast to recognize those risks, those signs and symptoms rather, of someone having a stroke. So is there a balance issue, a sudden loss of balance? Now, if you normally get around the house with your walker or your cane, and today you can't do it unless you use your furniture walk, right? You're leaning on the couch, then you're leaning on the counter, and you're still feeling wobbly, and you reach out and you fall, okay? That's a serious issue. If it's a sudden loss of balance, that's a warning sign. If there's a vision issue, now, understood, if you've been working on a computer for the last 16 hours and your vision's a little blurry, I can understand you could go to bed and figure it's going to be better in the morning. And I might even support that thought process. But if you woke up in the morning, you had breakfast, and then all of a sudden you had a visual loss or you had double vision, that's not normal. That's a red flag. And that might be something more than just your eyes. That might be neurological. That could be your brain trying to tell you that something is not processing or working well. Then we're back to our F for the face. Is the face uneven? And how do you tell that? Well, we always look at the eyes. Do the eyes open the same way? We tell the person to smile. When they smile, are they crooked? Well, you're not really sure. So you know what? Look at the teeth on both sides of the smile, and that can help you to determine if it's even or lopsided. The nose, does only one nostril go up when they smile, or is it both sides? So those are things that we look at when we look at their face. Is the face symmetrical or is it uneven? The arms. Do they have an arm weakness suddenly? Okay, so they're sitting at the table and then one shoulder goes down or one arm goes down. That's obvious. If it's not obvious, you can have them put their arms up. Does one drift while the other one doesn't? Or do they both stay up the same way? That can tell us that maybe there's a weakness on one side that's not on the other. And remember, stroke generally, if it's the one side, let's say the left side of the brain that's being affected, the right side of the body is going to show those symptoms. So we have to remember that. And again, with the leg weakness, if they suddenly feel like they can't support weight on one leg, well, that's odd, right? We shouldn't have sudden weakness in our leg. That would be a warning sign that we would want to address very quickly. Speech. Do they have trouble finding words? Do they slur their words? Do they sound confused? Maybe their words make no sense. So you say, I'm sorry, what did you say? Kickbox turtle water. What? I'm sorry, I didn't get that. Kickbox turtle water. And they're insistent that they're saying what they want to say, but those words aren't making any sense. That also is a sign that a part of the brain that's responsible for speech could be affected. And lastly, T for time. Time is brain. Just like a heart attack, when heart cells start to die, brain attack, brain cells start to die. Millions and millions and millions of brain neurons will die if we don't correct the problem. Are they the neurons that tell us how to tie our shoes, or are they the neurons that tell us how to speak? So that's when we always treat a stroke as a serious medical emergency. Now, time also has a couple of factors that we want to address. So BFAST, this is the symbol that you're going to see throughout all of our Atlantic Health, materials, your patient discharge materials. We've got posters in the waiting rooms throughout the hospital. Anytime we do an educational seminar, this is how we kind of put BFAST out there for everyone to see. And again, we want to pick up on those signs and symptoms early on. So with that, we talked about the facial droop and the slurred speech, visual disturbances, not being able to talk, unsteady gait or loss of balance, vision loss. What we didn't mention yet was that dizziness, weakness, numbness, and tingling. Also, we've got some of those signs like sudden onset of dizziness and nausea. Why are you nauseous? Because you're so dizzy, right? So we want to be able to recognize that that's not normal. Now, if somebody has vertigo, they know they have vertigo and they're extra dizzy today, you could probably think it's vertigo. I understand that. But if it's a sudden onset of dizziness, nausea, dizziness with some numbness and tingling, that crooked smile that we see in her picture, you can also look at her eyes. One eye is droopier than the other. So those are things that we need to look at, and we want to recognize that's not normal. And that's what we want to do, recognize and make action. Call 911. Time is critical. So we call 911 and we need to know when they were last seen normal and when we found that they had symptoms. So sometimes that's the same time. If you're sitting there at the breakfast table and somebody has that facial droop, they drop their coffee or their hand drops to the table and you were just with them, what's the time? Whatever time you called 911, right? You're going to call 911 right away. So that's going to be the time that they were last okay, as well as the time the symptoms started. And that is really important. We will make so many phone calls trying to find out when they were last seen normal because some of the treatments are time sensitive. Some of those treatments cannot be given after 3 or 4 hours after that onset. But if we don't know when they were last known well, we may not be able to treat them because when somebody found them with symptoms, we don't know if they were like that for an hour or 10 hours. So that's very important information. We also want to make sure that if we have any of these risk factors, if we have any signs and symptoms of a stroke, we have the right follow-up care. So we're going to make sure we hook you up with a cardiologist, a neurologist, an endocrinologist, and your primary care physician. So if you don't need the endocrinologist because you're not at risk for diabetes and you don't have any elevated numbers that would make you go down that path to see them, your cardiologist, your neurologist, and your primary care physician might be enough. But we're going to make sure that we tailor your follow-ups and your follow-up care with the docs that are appropriate for you. And it's really important that your primary care physician is like your general contractor. They should know who you're seeing and when you're seeing them because everybody is specialized. Your primary care physician is specialized in kind of overseeing your general care. But for the specifics with your neurology problems or that stroke, he's going to make sure that you're following up with your neurologist and they're going to communicate. So it's really important that you understand the follow-ups with these physicians all play a part in getting you well in recovery from stroke, or if we've recognized those risks early, we're going to try to minimize your risk by medicating, treating, or altering our lifestyle in advance. So medications. I know a lot of people don't like to take medications. However, what's important for us to keep in mind is that medications can be our friend. So some common medications that we see with cardiovascular and stroke patients: aspirins, and which would be an antiplatelet, a statin, which is going to help to lower those lipids from your cholesterol levels, your LDLs, insulin or metformin or Jardiance or any of those anti-diabetic medications, because uncontrolled diabetes is even worse of a risk than controlled diabetes. So it's very important that we manage our blood sugar so that your body is in better shape to process, get rid of any excess sugar, and it reduces the wear and tear on your organs. We know diabetes takes a toll on many of our organs, and we want to make sure that controlled diabetes will lessen those risks and lessen that wear and tear. So we want to keep the transmission and the engine doing well, right? We need to keep our oil in there. We need to keep the right fuel, maybe a little high octane. That's our medications. So that's what we're going to do. And we're going to keep that transmission going for thousands and thousands and hundreds of thousands of miles. And we're going to keep that engine going along without any knocks and without any bangs and without any stalls. Eliquis. Eliquis is going to be an anticoagulant. So Eliquis or warfarin, also known as Coumadin, if you are at risk for that atrial fibrillation or for forming those clots, then we want to make sure that there's an anticoagulant unless you are contraindicated. So if it's somebody that has frequent falls, an anticoagulant may be a worse risk than the risk of stroke, and the physicians will make that determination. So it's really important that you know what medications you're using, why you're using them, and if there are any risks associated with that. We really encourage our nurses and our pharmacists to talk with the patients and go over the medications before you go home so that you understand why you're taking them, you understand if there are risks in taking them, and you know what to watch for in those side effects. We also need to take our medications as prescribed. So, you don't want to skip days in your medications. You don't want to take too much or too little. That medication has been prescribed for you based on your health, your size, your well-being, and really meant for you specifically. So, which one are you? Are you the little guy raising up those big heavy weights? Or are you sitting back with your soda and your chips and just sitting back binge watching? Well, on a rainy day, we might all be there, right? But we don't want to do that every day. So let's get moving. I had so much fun with this picture. I have to say, I added this into Erin's. But if you look at that, as long as you're moving, it doesn't matter if you're the John Travolta from the big old disco days, or if you're living it up, shaking it a little bit. What we want to do is we just want to get out there. We want to get a little more exercise than what we've got going on. So some of those can be walking your dog, mall walking, hula hooping, jogging, dancing. Anybody like ballroom dancing? How much fun is that? Biking, recumbent biking, trail biking, maybe just walking on a treadmill a little bit. You can do that nice and slow. You can go really fast depending on how you're feeling and what you're doing. Even things like mowing the lawn, washing your car, even housework, believe it or not. We don't want to say that though. We want the guys to know that. So we want to go ahead and we want to just get moving more. If you have a lot of joint aches and pains, maybe water exercise is best for you. So swimming, synchronized swimming, water, even just exercising in a pool, walking in a pool can be really helpful. So there's a lot that we can do that isn't crazy. It isn't ridiculous, jazzercise or, those crazy bike videos that we all see. Strength training. We don't have to be lifting these big heavy weights. You can get a couple of 2-pound weights and just moving them. Let's say that, your back's really bothering you and you have to stay seated. That's great. You can stay seated. You can use little weights. You can just practice straightening your legs and lowering them back down, straightening your legs up, lowering them back down. There's a lot of chair exercises. You could just Google chair exercises out there, and it's amazing what you can do, how much you can actually gain mobility wise and just burning a few calories while you're sitting and exercising without the risk of falling. So there's an awful lot we can do. And for those that are really energetic and bendable, God bless. So there's yoga. There's so many benefits with yoga. The mind and body benefits that go along with that, truly tremendous. And it's a tough workout. Meditation is great for your mind and body as well. You can get centered, you can focus on just yourself, you can really kind of process stresses of the day. I've gone to some meditation classes because I wanted to learn a little bit more about it. And I find it to be very, very cool. Very nice to be able to just focus on something as simple as yourself and just focus your thoughts in your mind and try to clear your mind. It's harder than it looks, for sure. It lowers your blood pressure, it can lower your heart rate, and you really focus on your breathing, and it can really change your outlook. So certainly recommend it. The food pyramid. Now, you can find a lot of different food pyramids out there, but they're all going to tell us the main basic principles. What we need to do is reduce our intake of the bad sugars, the bad fats, right? We want to reduce our red meats, increase our white meats. So your chickens, your porks, things like that. We shouldn't be doing a whole lot of processed meats. When I first met my husband, he loved those Hormel platters, right? The sliced up pepperoni and sausages and the cheeses. Well, we still like them on occasion, but I've had to break them of that routine because there's a whole lot of bad stuff that goes along with that. Milk, cheese, dairy, it's good for our diet, but we don't want to do too much of it because again, we're going to, put too much of the bad, heavy stuff in, increase our fruits and our vegetables, increase our breads. Remember, not the white breads, but our breads and our cereals. We want to increase a little bit of those, balance it out. So you can find a couple different ones out there. I've got some more pictures over here. Basically, decrease your saturated fat intake. You want to raise your HD, not your LDL. So raise that HDL, fish, omegas. That's what we want to do. We don't want that full fat dairy, the red meats, a lot of processed meats, fried foods. Now, does that say you can't have French fries? No, I did not say that at all. You can have your French fries, but just not every day, right? Lower. If you're used to having French fries 3 or 4 times a week, try to cut it back to 2 and then take it from there. So cutting down and reducing that intake even a little bit will help in the end. Baked goods and sweets, and my golly, this is my soft spot. I love a good piece of pie or a good piece of cake. So what I try to do is I don't eliminate it. If I see a piece of cake that I really, really want, I'll get it, but I'm going to eat like a third of it. And then I'm going to call it quits, or put it in the fridge and have 2 or 3 more servings later on. So just really cutting it down. That's important. Good examples, we want to do eggs and shellfish, lean meats. That's what we want to do to increase our good fat intake and decrease the bad. And the healthy foods, basically you want color, right? Lots of colorful foods. And if you like visual aids, here's a nice visual aid of how your plate should look, right? Most of it should be the vegetables and the grains, a little more of the fruits, and then the protein should be the smallest on there. So that's an old picture that we've been seeing, I guess about 20 years now. But it really does help if you're a visual aid person to kind of portion out things. There's nothing worse than having a plate that's just filled with this huge steak, and then there's no room for vegetables or little potatoes or grains. So in summary, really important that we want you guys to have recognized some risk factors that maybe you have and identify those that you could change or identify those that could be modified. We want you to be able to recognize the stroke signs using BFAST. And again, balance, eyes, face, arms, speech, and time. Please know how and when to call 911. We would much rather transport somebody that you suspect is having a stroke and find out that it wasn't than not have them seek help or get help when it is a stroke and they've missed that opportunity for really important intervention. Now, I'm going to put my number up here. Oh, my number isn't there. I'm going to put my name up there just on the end, and I'm going to share with you. I am here at Hackettstown. Atlantic Health is Hackettstown, Newton, Morristown, Overlook, and Chilton, as you know, and we are all advanced primary stroke centers. If we have somebody that has a really severe stroke that might need mechanical intervention or might need neurosurgery, we're going to send them very quickly to Morristown or Overlook, depending on what their needs are. We have an absolute amazing transport system, either by ground or by air, that's going to get them the care that they need right away. But that immediate care at the local hospital is just as critical as that advanced care they might need later on. So don't bypass your close hospitals, okay? Strokes should stay local, unless the professionals on scene deem their needs are different. But we all have the ability to do the clot busters as we know them, or the thrombolytics, and that medication can help to dissolve those clots that are in that 87% of those ischemic stroke patients. So if they get here early on, they're not with any contraindicating risks that would disengage them from getting that thrombolytic, then they're probably going to be ruled in to get it, and the family will help to make that decision if that's appropriate for that patient. Thank you. Have a great night. Thank you so much, Melanie.
No, thank you, Lori.